Morning. As many of you may know by now, my name is Kate Elkington, and I am one of the Grand Rounds co-directors, along with Drs. Jeff Miller and Christine Undeni. And Jeff Miller is going to be moderating the Zoom portion of our rounds today. So as usual, before we start, I just have a few announcements. Next week will be the DeHersh Robinson Grand Rounds with Dr. David Geary, the Curator's Distinguished Professor at the University of Missouri. The title of his talk is Early Development of Number Knowledge, Identifying Risk of Learning Disability. Next week's session will be fully remote. I'd also like to highlight that on April 19th, so that is 2 rounds from now, in lieu of Grand Rounds, we will be joined by the Dean of the Vagelos College of Physicians and Surgeons, Dr. Katrina Armstrong, for an in-person meeting at 12:30. So please note the time difference at 12:30. As Dr. Armstrong updates us on her priorities for the upcoming year and elicits feedbacks from members of the department. So all staff, faculty, and trainees are strongly encouraged to attend, and we hope to see you all there. Again, April 19th at 12:30. So before I introduce today's speaker, I just want to remind our folks on Zoom of our process. So please post questions at any time during the talk using the Q&A feature at the bottom of the Zoom window, not the chat. And if you are a trainee, please put the word trainee after your question, as we like to try and prioritize trainee questions. And that goes as well in the auditorium, so please don't be shy. Also, we like to, as much as possible, try and involve our Zoom audience. So if you would like to ask your question yourself to our speaker, please write at the end of your question, "Can ask the question myself," and then Jeff can temporarily promote you as a panelist, and you can speak directly to our speaker today. Also, there are, just for folks in the auditorium, there are USB QR codes, at the front for CE credits for various disciplines, just to note that. So let's turn to our speaker for today. It gives me great pleasure to introduce Dr. Jae Sevelius, who is a clinical psychologist and a professor of medical psychology here in our department in psychiatry. They are also a research scientist at NISB. Dr. Sevelius received their PhD in clinical psychology from the University of Missouri and went on to complete their postdoctoral fellowship at the University of California, San Francisco in behavioral medicine before assuming a faculty position there in the Department of Medicine. In 2020, Dr. Sevelius served as a co-director of the UCSF Center for AIDS Prevention Studies and the Center of Excellence for Transgender Health before joining the faculty here in our department in the fall of 2022. Dr. Sevelius works with community-led research teams to develop and evaluate trauma-informed, gender-affirming health promotion interventions for transgender and gender-expansive people in New York, California, and Brazil. Dr. Sevelius also specializes in psychedelic-assisted therapy for identity-based trauma and holds a certificate in psychedelic-assisted therapies and research from the California Institute of Integral Studies. Dr. Sevelius is known internationally for their expertise in gender-affirming healthcare, including the role of psychological gender affirmation in mental health and well-being among transgendered and gender-expansive people. Dr. Sevelius's transgender health research program has been funded by the NIH, the CDC, the California HIV/AIDS Research Program, as well as numerous other public institutions and private foundations. They have published over 80 publications in an array of journals, such as the American Journal of Public Health, Transgender Health, AIDS and Behavior, and the Journal of Acquired Immune Deficiency Syndrome, or JADES. So we are thrilled to welcome Dr. Sevelius to Psychiatry, as well as to our rounds today. The title of their talk is Gender Affirmation, an Intersectional Framework Informing Intervention Science to Promote Transgender Health.
Thank you so much, Kate. It's really a pleasure to be here. Good morning, everyone. Thanks so much to the in-person audience for braving the elements and taking the time to be here in person, and also welcome to our Zoom participants. Thank you also for joining. So as Kate mentioned, my name is Jae Sevelius. I recently joined the faculty here at Columbia. I'm really excited to present my research to you today on gender affirmation and to talk about how I incorporate this framework along with the framework of intersectionality into my science on interventions. And a special shout out to my mentor and to the person who brought me to Columbia, Dr. Walter Bochting, who is the area lead of gender, sexuality, and health, where I'm now based. So just a quick overview of what I'm going to talk about today. I kind of wanted to get out of the way the top 3 questions I get asked at every talk. So I'm just going to talk about those right out the gate. And then I'm going to provide an overview of current concepts in gender affirmation and talk about how gender affirmation can serve as an intervention on the relationship between the stigma that trans and gender expansive people experience and negative health outcomes. I'll give you an overview of the intervention studies that my team and I have been working on using the model of gender affirmation, and then talk a little bit about future directions that I see as important in gender affirmation informed intervention science. So top question number 1, what do we mean when we use the terms transgender, non-binary, and gender expansive? These terms are always evolving and changing, so people like to ask questions about exactly what we mean. So as you may know, transgender people are people whose gender identity is different from the sex they were assigned at birth. That's a little bit different from non-binary, where non-binary people identify their gender in a way that falls outside of the male-female binary. So in societies like ours, where we really primarily tend to recognize just 2 genders, male and female, which we often refer to as the gender binary, non-binary people really don't see themselves fitting into those distinct categories. Gender expansive is a term that is being used more and more to acknowledge the many ways that people may identify, express, and explore their gender identity. And this is very much an umbrella term that is speaking to the diversity of people and their gender identity. And so people may or may not identify specifically as trans or gender expansive, but we use those terms as umbrella terms to talk about people who have gender identities that can be described this way. And of course, there are many, many different identity terms that trans and gender expansive people use to identify themselves. And these terms are constantly evolving. They change over time. They can change throughout a person's lifetime. Age cohort has a big impact on what types of terms people may use, geography, culture, and language, of course. And then we use the term cisgender to refer to people who are not transgender or whose gender identity is aligned with the sex they were assigned at birth. Top question number 2. Again, these are not necessarily my areas of research, but I just want to get these out of the way so that people can think of other questions to ask throughout the presentation. How many people are there in the US? Well, fortunately, the UCLA Williams Institute released a report last year that gave us an updated estimate of the US population, and they estimated at about 1.3 million adults and 300,000 youth. So to give you kind of a comparison to think about, that's roughly equivalent to the population of San Diego, California, or Dallas, Texas. And the way that gender identity was broken down in these estimates was about a third, and a third. So trans men were about 36% of the estimate, trans women at about 39%, and non-binary people at about 26%. And again, these categories, there's a lot of diversity among these groups, but this is roughly how it broke down. Top question number 3. This one's a little bit trickier, but it's very much in the media right now, so people are really wanting to talk about it. How often do trans people regret transitioning? It's actually very, very rare. The cases that we have are primarily anecdotal. A meta-analysis of 8,000 patients who had some type of gender-affirming surgery found that less than 1% expressed any type of regret. And the quote-unquote regret after social transition in the USTS, which was a report that was released in 2015 of about 30,000 transgender people, found that regret after social transition was about 1 to 3%, but that actually primarily included people who expressed regret because of some of the social consequences of transitioning. So maybe religious backlash against them from their family, or certain types of rejection and marginalization that they experience. So it's not necessarily that there were changes in their gender identity or that they regret the transition itself, but more the social consequences. There's a lot of misinformation about this due to flawed methodology in past studies. And I think it's really important if you consume information about this topic that you're really careful about sources and really think about how people are talking about regret. So when we talk about identity, we're talking about how we make sense of our place in the world. And specifically related to gender identity, just like any identity, this can be fluid over the lifetime. How we make sense of our place in the world can evolve. It can evolve with the context that we find ourselves in. It can evolve with age. And the options for identifying our gender are dictated by our culture. So like I mentioned earlier, our culture primarily just recognizes male and female genders. Other cultures have other options available, but those are dictated by one's culture. And all cultures have some sort of sanction or marginalization for not conforming to the culture's options that are available. And one of the ways that nonconformity, one of the many ways that nonconformity is sanctioned by culture is stigma. So stigma is the social devaluation of an individual or a group based on an attribute that that person holds or is perceived to hold. And research studies have really proliferated in the past decade or so, documenting how stigma contributes to negative health outcomes. And many studies are reporting extreme health disparities among trans and gender expansive people as compared to cisgender people. And so stigma, there's three types of stigma that we talk about. Enacted stigma is what we think about when we think about discrimination, for example. It's external stigma that is enacted upon us, violence, harassment. And this largely results from the person's visible minority status or known minority status. So the stigma is enacted upon the person because they're known to be associated with a stigmatized group. Anticipated stigma is the stigma that a person expects is going to happen to them, or that anticipation that external stigmatizing events will occur, the worry that I'm going to be discriminated against if I go to this particular clinic, for example. That's anticipated stigma. And the expectation of stigma itself can cause a great deal of vigilance, avoidance of certain situations, isolation. So anticipated stigma is something we think a lot about in increasing access to healthcare. Internalized stigma is stigma that's turned inward. So it's taking that external stigma that you perceive and turning it against oneself or one's community. And interestingly, research has found that this is potentially the most damaging kind of stigma, because it negatively affects the person's ability to cope. When you're internalizing the stigma, it's really, really hard to be resilient against those experiences of enacted stigma, and really exacerbates the anticipated stigma. So studies have shown that these types of stigma lead to mental health issues, depression, anxiety, PTSD, which of course then lead to behavioral health issues. Like I mentioned, healthcare avoidance, maladapting coping strategies, people using substances to cope with some of these effects, and lower levels of adherence to medical care, mental health care. In the case of HIV, we see lower levels of PrEP uptake and adherence, or adherence to HIV treatment for those who need it, which ultimately, of course, results in reduced access to healthcare, the health disparities that we see, and HIV-related disparities. So just a quick snapshot of some of the rates of enacted stigma that have been documented. The USTS 2015 survey is so far the largest survey of transgender people in the US. They surveyed almost 30,000 transgender people from all 50 states and found very, very high rates of enacted stigma. So family violence and rejection was really high. 10% just within the past year had experienced some form of physical violence from a family member. 8% had ever been kicked out of the family home. 30% experienced employment mistreatment, and that could include anything from verbal harassment to being fired for being trans. 54% in the past year had been verbally harassed. And then rates of physical assault and sexual assault, about 50% of the sample had ever experienced these things, and 10 to 13% had experienced them in the past year. So you could see that these rates of enacted stigma are really high. And when you know that these rates are being, this type of violence is being enacted against your community, that anticipated stigma would also rise, as well as the internalized stigma. So how do we intervene on the relationship between stigma and negative health outcomes? And so enacted, anticipated, or internalized stigma related to one's identity can result in what social psychologists call identity threat. So identity threat is that anxious, destabilizing feeling that someone gets when they're not being seen, when they're being erased, or they're being stigmatized. And those ideas, those stigmatizing ideas, are being projected onto that person and that person's experience. And that results in identity threat. So what social psychologists have found in multiple domains and with multiple types of stigmatized groups is that identity affirmation, or affirming someone or even oneself in a way that is related to the threatened identity, can act as an antidote to identity threat. And that identity affirmation can lead to improved health outcomes. And this has been shown not only in healthcare, but in academic performance and workplace performance and in other realms as well. So research with sexual and gender minority people has shown that experiencing identity affirmation improves physical and mental health. And again, this can include affirmation from family, from friends, from healthcare providers, and even can be self-affirmation. When we talk about identity affirmation in the context of gender, we talk about gender affirmation. And often when people use the term gender affirmation, they immediately think of medical gender affirmation, which is the utilization of gender affirming medical treatments such as hormone therapy or surgeries. Sometimes we talk about these as embodiment goals of the person, reaching a person's embodiment goals through medical gender affirmation. But in reality, gender affirmation actually is comprised of several domains that all overlap and interact with one another. So for example, social affirmation is that social recognition and respect that is communicated by another person who's acknowledging your gender identity. And this can be improved through training and education, but it also interacts with medical gender affirmation, because sometimes when a person is reaching their embodiment goals, they find that levels of social gender affirmation also rise. Psychological gender affirmation is that internal sense of valuing oneself as a transgender or gender expansive person. It's being comfortable with one's own gender identity and expression, and can also include body satisfaction. Legal gender affirmation is also something that we don't talk enough about, the importance of having legal documentation such as a birth certificate or a driver's license that reflects one's affirmed name and gender marker. And again, this interacts with social gender affirmation, medical gender affirmation, and psychological gender affirmation, such that these levels of gender affirmation can all inform and affect one another. So one of the things I did really early in my career to understand this concept of gender affirmation and explore people's experiences of it is I did a ton of qualitative data collection. I did over 80 individual interviews. I did multiple focus groups, really talking about gender affirmation with trans and gender expansive people to start to understand the different dynamics and dimensions of gender affirmation. And one of the interesting things I noticed was that not only did their embodiment goals differ, their access to gender affirming relationships differ, their levels of psychological distress differed, but their need for gender affirmation varied. So whether or not they desired medical gender affirmation could in a way be a protective factor, and the receipt of gender affirming care for any desire they did have was also a protective factor. So what we found was the higher that the person's level of access to gender affirmation was in these different domains, the more protective factors people had. And just a note that gender dysphoria is currently the DSM category that we use when working with transgender people, and that there's some controversy associated with that. But then this other term, gender euphoria, also came out of those interviews where people really talked about feeling celebratory of their gender identity and not necessarily feeling distress or dysphoria about being a trans person or about having embodiment goals that they were still aspiring to. So what we saw was that when access to gender affirmation was high, we saw the lowest risk. So when need for gender affirmation was high, but access was low, it created this unmet need for affirmation, which really was also associated with some of the risk behaviors that we saw, which people were trying to meet their gender affirmation goals in ways that were risky, like, say, for example, buying hormones on the internet and taking hormones without medical supervision. Injection silicone was also something that we talked with many transgender women about, that was a kind of a quick and easy way to reach their embodiment goals. And so one of the things that came out of this was, how do we effectively increase access to gender affirmation for people that need it? This is just a quick snapshot of the framework that developed out of these qualitative interviews, where we incorporated the social psychological concept of identity threat as sort of analogous to the unmet need for gender affirmation that we saw, and conceptualized how these lead to negative health outcomes. So this is the conceptual model that has ever since really informed the interventions that my team and I have been developing. So we also, from the get-go, the model of gender affirmation incorporated this idea of intersectionality. And actually that paper was published in a special issue of Sex Roles focused on intersectionality. But we, more recently, intersectionality has come into the spotlight, and we've really thought even more intentionally about how to incorporate this concept into our interventions. So intersectionality is a term coined by Kimberlé Crenshaw, who's actually here at Columbia Law School. And she defined it as a lens for seeing the way in which various forms of inequality often operate together and exacerbate each other. So for example, a Black transgender woman experiences both racism and transphobia, but also experiences sexism. And none of these things are separable from each other. They all inform her experience to create her unique social context. And so it's really important to think about how, for example, a Black trans woman's experience may differ from a white trans woman's experience, whose experience will differ from a white trans man. And so really understanding how we might be able to infuse this idea into our programming for communities was really important to us. Just always have to give a shout out to Lisa Boleg, who's one of my primary mentors and does a lot of amazing work in intersectionality. And she talks about how the interplay between racism, sexism, other forces of oppression can affect our daily lives. So how these macro forces of oppression then intersect at the individual level to impact our individual level experiences, and that these the interactions of these forces shape our access to things like healthcare and other forms of support. So Dr. Crenshaw initially conceived the concept of intersectionality to explain the oppression of African-American women, but it has evolved into a framework for public health researchers and other researchers, and as a tool for advocates and communities to understand the lived experiences of people who face multiple intersectional harms and to take action to address them. So we all belong to multiple social categories that intersect with one another, and those create our unique experiences. But for those whose social position is at the intersection of multiple types of oppression, such as racism, transphobia, and other stigmatizing forces, they create a social context of increased vulnerability and increased risk of negative health outcomes, such as poor mental health. So how do we infuse these frameworks of gender affirmation and intersectionality into behavioral interventions? So one of the most important ways that we have done this is to ensure that the programs that we develop are truly community engaged. So I have the community engagement continuum here where, outreach is one way, but it is actually a fairly small way of engaging the community. And that goes from outreach to true leadership. And so we really sought to engage communities as true collaborators and leaders in the programming and research that we were developing from the beginning. And in this process, we found 4 key elements that are critical to gender-affirming behavioral interventions with trans and gender expansive people. And one is that they're peer facilitated. Peers are trusted bridges between stigmatized communities and the clinical settings that we are trying to bring them into. So we really have learned that this is a critical aspect of addressing things like medical mistrust and disconnection from the healthcare systems and healthcare avoidance. Our interventions are truly trauma informed in the sense that information about trauma and training about trauma is infused into our interventions, both in terms of the content, where we're educating people about trauma and the impact of trauma on their health, but also in terms of process. So educating peers about how to recognize when someone is in a trauma response. How do you respond to somebody who is triggered in the moment? And this is really important for interventions where peers are helping people navigate healthcare systems that can be potentially quite triggering. It was also important that these interventions are community-led. So we wanted trans and gender expansive people to have a true sense of ownership over the programming and really make those programs our own. So in every way that we could, we made sure that we were following their lead. And then, of course, intersectional. So we always seek to understand and address how multiple elements of people's experiences are impacting their health. So the majority of research on transgender health to date has been conducted in the area of HIV. There are really extreme disparities in the realm of HIV, and this is where we sought to focus when we were first developing our gender-affirming behavioral interventions. Overall, estimates of HIV among transgender people are around 14%. It's higher among trans women and even higher among Black and Latina trans women. There's not a lot of data about HIV among trans men and non-binary people, but estimates are around 2% for trans men, and we don't have enough data to break that down by race ethnicity, but we can imagine that it probably mirrors some of the disparities that we see in other groups. And estimates among non-binary people actually also come from the USTS survey that I mentioned earlier, and the estimate is about 0.4% with higher rates among those who were assigned male at birth. So this is a quick snapshot of the interventions that my team and I have been developing and working on over the years. These are some of the amazing people that I get to work with in my research and programming in San Francisco, Los Angeles, Detroit, Sao Paulo, Brazil, and some of the logos from the different interventions that we've developed. And of course, all of the names, the logos, the branding of the studies are all developed by the community. So the first behavioral intervention I'll mention is Shiro's. This is a group level intervention that was developed, of course, in collaboration with community, where small groups of transgender women, about 6 to 8 transgender women, will meet together over 5 sessions, either weekly or bi-weekly, and we train peer facilitators to facilitate these groups and focus on these different session topics. Shiro's was unique, especially at the time we developed it, because it was a mixed HIV status group. And so typically HIV interventions are segregated by HIV status, but we realized early on that transgender women don't naturally segregate their communities by HIV status. And it was really important for us to not reinforce HIV stigma and to build community. So we conducted a pilot RCT with R34 funding. Here's some of the intervention sessions and topics that we focused on in the intervention. So you can see how gender affirmation is infused throughout, looking at how trans people have existed throughout history and around the world. So really talking about trans people who have been recognized as historical figures, and then exploring some of people's ideas about what it means to them to be trans, what trans community means to them, talking about gender affirmation and how it impacts health, talking about different forms of self-care, healthy forms of self-care, potential impacts of riskier behaviors, of course, providing accurate information on HIV and other types of health, and ways of coping, including basic self-defense information. And so here are some of the things that some of the participants said about Sheroes. One participant said, "I feel very empowered and blessed to have had this experience with my sisters." So again, speaking to that need for social cohesion, community building. One woman said, "I learned how to take better care of me in all kinds of ways." So self-care and alternative strategies for self-care when the strategies for coping that people are working with maybe aren't working as well as they would like. It helped me to feel better about myself and want to make changes to stay healthy. So increasing that sense of internalized gender affirmation can increase motivation to engage in healthy self-care. So in the pilot RCT, we found that at 6 months, compared to control, intervention participants reported significantly decreased number of condomless sex partners, decreased total number of sex partners, and increased social support. So you can start to see how infusing these concepts throughout the interventions can translate into healthier behaviors and better social support. Another intervention that we've been working on for many years now is called Healthy Divas. And Healthy Divas, as distinct from Sheroes, it's actually a one-on-one intervention. So it's peer facilitated, and we train a peer counselor to work one-on-one with participants to set individualized healthcare goals, and then help the participant, support the participant in working through any challenges in meeting those healthcare goals. So she provides resources, support, skills building, and the goals are really set by the participant, but tend to be related to things like gender affirming care, medical care, mental health care. And during those 6 individual sessions, sometime in that 6 to 12 week period, we conduct a group workshop with everybody who's going through Healthy Divas and healthcare providers. So 1 to 2 healthcare providers who have expertise in both HIV prevention and care, as well as gender affirming care. And it gives people an opportunity to ask their providers questions they might not feel comfortable asking their own primary care provider, and to hear from other women about what their healthcare experiences have been like. So we conducted a randomized control trial with 278 transgender women in San Francisco and Los Angeles. Over 90% of our participants were of color, primarily Black and Latina trans women. And at 6 months, we found that participants in the intervention arm had over twice the odds of being in a higher HIV care engagement category than those in the control arm. So what we did in terms of HIV care engagement was we created a composite variable that included all of the elements of HIV care engagement that we would want to see, such as being on antiretroviral treatment, being adherent to HIV retroviral treatment, engaging in HIV healthcare, so seeing a healthcare provider at least every 6 months, and knowing your recent CD4 count. And we had a very high proportion of people in our study who weren't on ART at baseline. And so we separated those groups out to make sure that our intervention had a similar effect for those who were on ART at the beginning of the study as those who were not. So in Brazil, we've been working there for about 8 years now, and building different programs, testing different strategies, learning more about the context. And what we're doing now is combining the approaches of Sheroes and Healthy Divas, where people go through the groups, do some psychoeducation, build social support, and then transition into the individualized peer counseling and navigation to promote uptake of HIV testing and PrEP. And so we've been focusing on how our interventions reduce intersectional stigma, and how that in particular is the mechanism for increasing HIV testing and PrEP. Another question that we've had as we've developed these interventions is about how to understand the implementation of these interventions in different settings. So how do community-based clinics differ from CBOs that primarily serve transgender people? That was the question we had for Triumph, and it was the first demonstration project initiative to focus specifically on transgender communities. And so we used community mobilization strategies to kind of get the word out about PrEP, because this study was conducted at a time where PrEP was really being primarily marketed to gay men, and trans women weren't sure if PrEP was really for them. And actually, we still do hear that quite a bit from trans communities. And so these community mobilization strategies were really about educating communities and getting them excited about PrEP. And we also, of course, used peer health educators. And we worked with La Clinica in Oakland, which is an FQHC serving Latinx communities in Oakland, who had a lot of experience with PrEP provision and HIV care, but very little experience serving trans people. And then we kind of compared that to Gender Health Center, which was primarily focused on serving trans people and had a lot of experience providing mental health care and hormones to trans people, but really no experience providing PrEP or any type of HIV care. And so looking at what are some of the challenges and opportunities in these different settings to provide PrEP and to increase access to healthcare for trans people. And we did capacity building at both sites and then looked at some of the opportunities and challenges. And what we found was that in both cases, peers really served as this bridge. So people trusted that first line of information. So for La Clinica, for example, we were able to get some Latina trans women into La Clinica who had never accessed medical care in the US, despite having been here in this country for decades, because they didn't trust the US healthcare system. And so by having Latina trans women recruiting and educating their own communities, that bridge was absolutely critical. Similarly, with Gender Health Center, information about HIV and about PrEP, people had a lot of questions about, is PrEP going to affect my hormones? How is this going to impact my gender journey? And so having peers deliver that information as sort of a first line of entry into the healthcare system was really critical. We've also looked at correctional settings, and we worked specifically with San Francisco County Jail to look at the experiences of transgender women in particular who were being overly targeted and overly incarcerated in San Francisco. And we really heard these stories in the context of our other programming, where many times when we couldn't find a participant and we had tried everything and contacted their network, they were in jail. And even being incarcerated for a short period of time, 2 days to 2 weeks, was very disruptive to people's lives. And sometimes they even lost their housing when their housing was already unstable. 2 weeks can be just enough for them to lose their housing situation. So we wanted to understand more about how we could utilize peer navigators and peer educators to go inside the county jail, talk to trans women, create individualized reentry goals for them, and then help them navigate the system upon reentry. And again, the importance of peer facilitators came through again and again. We had to do very facilitated referrals to gender affirming community resources, because even in San Francisco, which has a reputation for being more resourceful when it comes to trans service provision, we still had to make sure that we identified a point of contact at each of these community resources who understood what we were trying to do and was going to be affirming to our participants to ensure that any of the referrals that we gave didn't result in negative experiences for our participants. And then obtaining programmatic buy-in from jail staff and administration was also somewhat challenging, but ultimately we did find that Girlfriends Connect was feasible and acceptable by both the community and the San Francisco County Jail. And we're continuing to think about how we might be able to expand this programming. This initial pilot was just published in the Journal of Correctional Healthcare in a joint issue with the Transgender Health Journal focused specifically on transgender healthcare in correctional settings. So it's a very interesting issue. So currently we're conducting a number of implementation studies looking at how we can expand implementation of these programs and what we can learn from the community-based organizations that are implementing them. We're conducting an implementation study, which is a hybrid type 3 of Healthy Divas. We're also conducting a hybrid type 3 study of Triunfo at La Clínica de la Raza, which was one of the clinics in the original Triumph study. And we just got a new study funded called Let's Be, which I'll talk more about, that we'll actually be implementing here in New York City. We created an online learning center for Healthy Divas for organizations that are interested in learning more about Healthy Divas and how to prepare their organization for adopting the intervention, how they might tailor it to their particular community. And then there's all of the training materials and facilitator manuals, which have all been updated to be a status neutral intervention. So one of the things that we learned during our implementation studies is that even though Healthy Divas was originally developed for women living with HIV, it can actually be adapted for any healthcare goals that transgender women might have. And it's currently being adapted by researchers at the University of North Carolina for an economic empowerment intervention, which I think is really interesting. So the framework for Healthy Divas can actually be applied to all different types of life goals, which is really exciting. So Let's Be, which I mentioned earlier, is it's a implementation study, which is a hybrid type 1 effectiveness implementation study. So the hybrid type 1s are ones where we're primarily collecting data about effectiveness of the intervention and secondarily also learning from the implementation. And so my MPI, Christy Gamarel, who's at University of Michigan, and I have been working on again, taking the group context of Shiro's, combining it with the one-on-one of Healthy Divas, and creating a HIV status neutral intervention where we're looking truly at the feasibility of doing an intervention like this in a hybrid type way. So with COVID and with telehealth being so prominent in our new era, and with some of the technological challenges that we saw some of our participants having in adapting to things like Zoom facilitated intervention sessions, we wanted to systematically evaluate how an intervention might be delivered in a telehealth hybrid in-person format and what some of the implementation challenges of that might be for clinics and providers and for the participants themselves. So we're partnering with Corktown Health Center in Detroit and Callan Lord here in New York City to test the implementation of Let's Be. And just wanted to give you a snapshot of the theoretical framework that informs Let's Be, so you can see how we are very intentionally infusing intersectionality and gender affirmation frameworks, as well as the core elements that I discussed earlier, into the intervention and how we theorize that this is going to work to improve HIV outcomes ultimately. So a few words about future directions in intervention science with trans and gender expansive people. You know, as a clinical psychologist, I've always been primarily interested in how mental health impacts health behaviors, health outcomes, and more we are recognizing how urgently mental health interventions for trans and gender expansive people really are. The disparities are enormous. As we know, mental health care is an urgent need for all communities, especially in this country where we have a lot of work to do in terms of infrastructure for providing mental health interventions. But for trans and gender diverse people who face a lot of stigma, this is particularly urgent. And one of the things that we have thought a lot about is how current conceptualizations of PTSD and some of the treatments that we offer for PTSD don't translate very well to trans and gender expansive communities who experience continuous traumatic stress related to their identities. So traditionally, we think of PTSD as trauma that happened in the past that's impacting a person's mental health in the present. That trauma may or may not be related to a person's identity. But as I mentioned earlier, when a person is internalizing that kind of trauma, that identity-based trauma really produces a unique manifestation of symptoms and requires unique types of treatment. So continuous traumatic stress really has to do with ongoing exposure to traumatic situations. And this may or may not be related to a person's identity depending on the context, but for transgender people just living in a society that marginalizes them and stigmatizes them for their identity, that constitutes continuous traumatic stress and can result in symptoms that mirror PTSD and complex PTSD. So one of the breakthroughs that has happened in the last couple of years is that the FDA has granted breakthrough therapy status to MDMA-assisted therapy for PTSD. And as we know, PTSD prevalence is really high among the US population in general, but is particularly high among trans and gender expansive people. And existing PTSD treatments are largely inadequate. They're very difficult for participants or for clients, patients to tolerate, and more than 50% of folks with PTSD still experience symptoms after therapy. And trials of MDMA-assisted therapy have not to date included trans people or explored how applications of MDMA-assisted therapy might address their unique forms of identity-based trauma. So we're doing some initial formative research to identify some of the unique needs for MDMA-assisted psychotherapy with gender expansive people, using focus groups, talking to trans people who have a history of engaging in trauma therapy. We're doing a survey of sexual and gender minority adults with a history of psychedelic use to explore how psychedelic use has impacted their identity development and integration. And then in-depth interviews with gender expansive adults who have a history of psychedelic use. And we're doing this in conjunction with folks at Ohio State University, Dr. Alan Davis, who leads the Center for Psychedelic Research there, and Dr. Chris Stouffer at the Oregon Health Sciences University in Portland. And so at the heart of gender affirmation, intersectionality framework, peer-facilitated interventions, all of this science is really about being affirmed, being seen for who you are, being validated, and really being able to internalize that type of affirmation. And it's so incredibly important, especially in healthcare settings where people are seeking help, who may be in vulnerable positions. And so it's really important that we think about how we might improve our healthcare settings, how we might train our healthcare providers to make sure that we're providing the most affirming care that we can to all of our patients. So just another snapshot of my team. Thank you so much for your attentive listening today and the opportunity to present my research.